So as we look ahead to 2030 and the global goal of ending HIV as a public health threat by that point, it's clear that preventing new infections has to be a key element of a sustainability strategy. Now, currently, some 30 million of 40 million people estimated to be living with HIV worldwide are on antiretroviral treatment. And this is with the expectation that they will need to take antiretrovirals for the rest of their lives, potentially several decades, to suppress the virus, reduce the likelihood of transmission, and to lead healthy lives. Now, ensuring people at risk of HIV have access to a variety of prevention options that they can use when needed could be a huge step forward in limiting the number of new infections and eventually reducing the need for people to be on lifelong treatment. How to make a variety of prevention options available, affordable, and acceptable to people who need them is the critical question. Hello, and welcome to CSIS. My name is Catherine Bliss. I'm a senior fellow with the Global Health Policy Center here, and I direct our work on immunizations and health systems resilience. And it's really a pleasure to have an opportunity today to moderate this conversation about HIV prevention options, including daily PrEP and long-acting PrEP methods, PrEP being pre-exposure prophylaxis, and what it will take to make sure people at high risk of HIV are able to affordably and equitably access highly effective products. We have a fantastic lineup of speakers, including Ambassador John Nkengasong, U.S. Global AIDS Coordinator and Senior Bureau Official for Global Health Security and Diplomacy at the U.S. Department of State, Jared Baton, Senior Vice President for Clinical Development and Virology Therapeutic Area Head at Gilead Sciences, Alex Reinhardt, joining us online, Senior Director and Medical Development Lead for Prevention at ViiV Healthcare, and Zonke Tembe, DREAMS Ambassador in Eswatini. And DREAMS, of course, is the public-private partnership for determined, resilient, empowered, AIDS-free, mentored, and safe partnership focused on adolescent girls and young women. Now, for a little bit of background, oral daily PrEP was first approved by the US Food and Drug Administration in 2012. The World Health Organization recommended it 3 years later. But it's really just been in the last 3 years, since 2021, 2022, that access to and uptake of daily oral PrEP has really scaled up, particularly in the low and lower middle income countries where the HIV burden is the greatest. And there may be many reasons for this delay, from supplies and financing arrangements to planning gaps, and of course challenges with how PrEP has been marketed or recommended for vulnerable populations. When daily PrEP, while it is highly effective, taking a daily pill to prevent an infection or having to return to clinics for regular monitoring may be challenging for people who are on the move or who don't want to have to go to a clinic in the first place, who may be looking for something more discreet. So now, with several long-acting options, including the monthly vaginal ring, the bi-monthly injectable cabotegravir, the new long-acting options working their way through research and development and regulatory approval, such as lenacapavir and others, it's really important to consider what can be done to close the gap in access to newer products for people at highest risk. Now, from June to October of this year, the CSIS Bipartisan Alliance for Global Health Security convened a working group with support from Gilead. And the focus was really on considering what steps may be helpful in working now as products are coming online, as they move through regulatory approval, and as they really become available. What can be done to ensure accelerated access to new tools in the settings where they're needed the most? In putting together a brief analysis, the working group assessed gaps in clinical, behavioral, and implementation science, country needs with respect to financing, regulatory approvals, and planning, and importantly, the critical role of community groups in raising awareness and driving demand about PrEP. We also looked at the opportunities that exist for organizations and programs like PEPFAR, the Global Fund, and national governments in collaboration with the private sector and civil society to really move the agenda forward. So we hope that the analysis and may provide lessons not just for continued focus by PEPFAR and other organizations on PrEP, but also really looking ahead at some of the multi-purpose tools, such as combinations of PrEP and contraceptives or STI management, as well as other kinds of long-acting tools that may be relevant in terms of thinking about affordability, access, and acceptability over the longer period. So to get our conversation started, I'm really pleased to turn to Ambassador John Nkengasong to offer some keynote remarks, really helping to set the stage for how PEPFAR, which has historically in the last period really been the largest procurer and driver of purchases and delivery of PrEP in the countries where PEPFAR is working around the world. How does PEPFAR really see PrEP within the larger context, not just of HIV prevention, but really the sustainability agenda? And as you think about the work that you've done over the past few years and the challenges that lie ahead, what are you really, what are the priority actions that you see over the next critical period?
Thank you, Catherine, for the invitation to share these reflections this afternoon. Let me start with this, that we've come a long way, and I would approach this from where PEPFAR sits, is look at 21 years ago where we were and see where we are today. So that is one. Second thing I really like to underscore is that we are dealing with a retrovirus. So we may not be able to use the word eradicate or eliminate, like we did for smallpox. It's a retrovirus. I remind myself about that every day. It's a very basic concept, but I remind myself about that every day. But look, we have the tools that, I call it combination tools. That is treatment, and the new tools that are coming on the long-acting injectable. Our unique focus in the fight against HIV/AIDS has to be our ability to reduce the rates of new infections to a level that, excuse me, we can consider that we are controlling the virus, not eradicating it, not eliminating it, but controlling the virus. I say this because I always like to celebrate our progress. Many countries, about 10 countries, have achieved and exceeded the 395. 95% of people who are infected knowing their status, 95% on treatment, 95% receiving viral load suppression there. But even when you look at those countries that have exceeded that, and what bothers me a lot is the rate of new infections. Just a couple of weeks ago, Dr. Bernard and I were in Botswana, looked at their data, congratulated them, but that warned them and said, look, you have 4,300 new infections. Last week or 2 weeks ago, I was in Malawi, same story. Look, a small country, relatively small country of 21 million people, 14,000 new infections, mainly amongst adolescent, young people as a whole. So that's not a winning formula. We cannot. So first of all, we have to put this long-acting injectable or prevention as part of the sustainability program. How do we sustain the gains we've achieved over the years? That is to say, shrink the pool of people that will be requiring treatment between now and 2030 and beyond, and reduce the rate of new infections, what we commonly call close the tap of that. I think that is where I'd like to focus the second part of my reflection. Now, if you look at the UNAIDS incident projection, it tells you that last year we had about 1.3 million new infections. Yes, we are bending the curve, but the curve is not bending fast enough. We were supposed to be, at this point, projected to be having less than 500,000 cases of new infections. We are 1.3 million. So again, making progress. We should avoid confusing that progress with success or declaring victory. We still have a lot of work to do. But we are very fortunate that we have some new tools there. Now, the new tools that we have, we've been asking for these new tools from the private sector, the companies to develop that. They develop it. We have them now. what would be a tragedy, and a tragedy of unimaginable proportion, is to have these tools and get into the valley of death, where we have the tools sitting on the shelf and we do not get that into the right population, that is. And what are those? In my view, very early on, it should be young men who have sex with men, because that is, if you look at outside of Africa, that is where the rates of new infections are rising significantly. Philippines, I was there this year, and over the last 10 years or so, the rate of new infections have increased by almost 400%, mainly amongst young MSM. It should be about discordant couples in countries, high-burden countries. It should be about young people, adolescent girls, and young women, and others that we really have. So the point I'm making is that we should be excited with these new tools, but be very clever in the way that we deliver the tools in a way that is very targeted, is driven by science and evidence, is driven by the ability to scale up rapidly, and scale up consistently, because again, there's a whole education that needs to occur and information that needs to occur around the availability of new tools. For example, this is not a vaccine. So if you get a young person, and you make sure they know that if you go get your one shot preventable, we call it Cabilade or lenacapavir, that is not a vaccine, that you have to be obedient, you have to come back every 2 months or every 6 months and do that. And we have to be determined that we are committing ourselves, but the partner countries and donors and partners like PEPFAR, the Global Fund, Gates Foundation, that we will do this consistently for about 5 years. So okay, that is where we begin to see that a tipping point, okay, where we see the rates of the infections coming down to a level that you can control that. I would love to see this in Botswana, where the next time I go in 5 years, and you look at their data, you see 500 new infections or less a year amongst young people, because we've lent them or we've cap-laid them consistently for 5 years, and you reduce that. At that point, you begin to see the pool of people that you are treating shrinking, because people will leave their normal lives, and then, of course, they will subsequently die naturally because of that. But then you are not increasing that pool. That is part of sustainability. Sustainability should not be seen only in the lens of financial, but it should be looked at in the lens of the political leadership of the countries that are beginning to be vulnerable to their own success. When you go to the countries, you don't see the head of states talking about HIV as a priority, but they are aware of the danger that it created to them. So my message to them is that please, let's go back to elementary school and have primary prevention. Make sure that you talk to the young people. Use your voice. Your voice matters in this. So the point there I'm making is that, yes, it's about long-acting injectable or prophylaxis, but it's also about primary prevention. It's about biomedical prevention, but it's also about treatment. Just in some, reducing the rate of new infections through treatment scale-up, but also reducing the rate of new infections by the new tools that are becoming available. It will be critical.
Thank you. So, Jared Bainton, let me turn to you. The ambassador has, really reminded us, and the goal by this point was to get to 500,000 new infections or fewer in a given year. Yet, in the past year, we saw more than 1 million. And you've been involved in PrEP, both through the research of oral daily PrEP, and then now more recently the work on lenacapavir as PrEP, through the different purpose trials. What have you seen over this process, really about the importance of making sure, as products, become available and as options are made available, to have the production, financing, and regulatory and planning issues really kind of considered from the outset? What do we need to be thinking about, in terms of advanced planning to make sure this can be a reality?
You're exactly right, and thank you. I think earlier you introduced me as having done this for many years.
Yes.
And it's, so I'll say it back on myself. I think for those of us, and I have done this for many years, and I think I would reflect back on what PEPFAR has brought to the world, because I've practiced HIV care here in the United States, in public hospitals, and in other settings, as well as in East Africa, and I can remember very well when the coffin makers went out of business because there were fewer deaths, because of the work that PEPFAR has done. And so that investment in reducing deaths first, now it needs to be translating into reducing new infections, because we have come very far, and we're also far behind where we could be. Now I work on making new HIV medicines for treatment and for prevention, and we've been doing work this last year on an investigational medicine for HIV prevention that can be that's delivered twice a year, that has the potential to provide a new prevention option to people. And all that scientific innovation has no benefit unless it actually translates into equity and access. And that's something that is done in partnership, and that's something that's done with planning. To your question, the work to be able to think about long-term planning for access has to happen at the same moment as you're thinking about the beginning of the science work that you're doing. Mm-hmm. And that is, for our programs, that has been engaging community and policymakers and scientists and governments in the planning of the trials that we're doing, so that the trials have been able to be as inclusive as possible, to be able to include adolescents and women who become pregnant through pregnancy and breastfeeding, to be able to include populations from across multiple continents, so that the work speaks across multiple places. That's also planning for access from the beginning, and that is licensing to be able to, for example, for our investigational product. At the time we had readout from the phase 3 trials, we also announced voluntary licenses for generic manufacturers to make high-quality, low-cost generic products for places like where PEPFAR works and in 120 countries around the world. To be able to then facilitate those generic manufacturers to be able to make products sooner, because it's the technology scale-up to make something new is not a trivial process and needs support and partnership. And then to work with procurers and governments and other stakeholders to be able to make both the case for ongoing HIV prevention and to be able to make the planning for it. This is work that's an ecosystem. And it is all of us playing our part together and really leaning in. I think, to the ambassador's point, we have tremendous opportunity that that many of us who worked in HIV for a very long time don't think we've had before, to be able to think about really making a difference across all of the things that we do and all of the places that we work from, to be able to turn off new infections really in all around the world. And that is every piece of the work. That is science, that is equity, that is access, that is delivery. The work does not end with a p-value or a fancy publication. I like being a scientist, and I've done this work for a long time for p-values, but that's not what actually gets impact to populations in this country or anywhere else. It is working all together in partnership and planning and leaning in and going for the long haul, because this is work that can make a tremendous difference.
Great. Well, thank you. So really, taking that long, multi-year approach to planning for not just the research, but really the full implementation. Alex Reinhardt, let me turn to you. Thank you for joining us today. So ViiV's long-acting product, cabotegravir, for PrEP, was introduced in 2022, if I'm not mistaken, and it's now starting to be, it was available in some of the high-income countries, and it's now starting to be introduced more widely in the lower middle and upper middle income countries. And I know there are, in addition to the approvals, there are a number of implementation studies going on. What lessons have been learned over the past couple of years with this, the long-acting injectable, that you see helping to, or that could be applied to accelerate availability and affordability?
Yeah, thank you. So thanks to the organizers, CSIS, for the opportunity to speak on behalf of ViiV, and apologies that I can't be there in person. we're in the unique position now that we're beginning to see long-acting cabotegravir move out into the wild, so to speak. Now we're well past phase 3. The open label extensions are winding up, and we're beginning to introduce cabotegravir now into implementation science projects. I think there are about 9 of them going on globally right now, with a few in the U.S. and some in Eastern Africa, as well as Latin America. And now we're beginning to see programmatic rollout through PEPFAR and other donors as well. I think to build on the comment that Jarrett made about kind of the impact to populations, I think what we're seeing now as data emerge from these projects, I think is very, very encouraging, and I think bodes well for the future for all long-acting products. And what we're seeing is we're seeing very, very high rates of persistence now with long-acting cabotegravir. 80% or higher, in some cases greater than 90% now. People are returning for their injections. I think from a public health point of view, what's maybe even more exciting now is we're seeing the expansion of the populations that we're reaching. People who had never used PrEP before are now coming in large numbers now to receive cabotegravir. This is evident now in the Search Sapphire project in Kenya and Uganda. We've seen it in Cape Town in South Africa. We've seen it here in the U.S. as well. These are all really positive markers, I think, now for the introduction of yet a new option in addition to daily oral therapy and the vaginal ring. We're seeing also, we can't underestimate the importance of the continued efficacy that we observed in phase 3 in the HPTN studies. We're still seeing that very, very high level of efficacy maintained even in these implementation studies. It's too early to determine for programmatic rollout. That's just really beginning, but I think the early returns are very, very positive. And frankly, I think it's important now that we have some real choice available for participants. As you mentioned earlier, 2012 was when daily oral TDF-FTC was available, and then there was quite a period of time where nothing else was available, and then the vaginal ring came, and now we've seen CAB, and probably lenacapavir is waiting in the wings. So now we have some real opportunities for choice for participants, that they can choose whatever works best for them at that moment of time in their lives to help prevent the acquisition of HIV.
Right, well, thank you very much. And kind of building on your point about choice, I want to turn to Sonke Tembe, who's joining us as the Dreams Ambassador from Eswatini. And Sonke, you work through your ambassadorship with young women, adolescents and young women, and really youth kind of across your country, but also with the other ambassadors as well. And could you say a bit about the way in which the groups that your peers who you're engaging with are thinking about HIV prevention at this point, and the importance of choice and having options, in the consideration around prevention?
Thank you so much for the opportunity, and I would really like to also appreciate our previous speaker on raising the importance of choice. As young people, adolescent girls and young women, we appreciate all the commodities that have come into play. Thank you to PEP for funding the ambassador, initiating the funding. Maybe looking back in Eswatini, we received oral PrEP, firstly dating back in the year 2021, and we then received the ring recently, and then the CAP-LA, which is a long-acting injectable. We appreciate the variety of options because we do not have the same lifestyles. We are also experiencing gender-based violence in our different spaces of life. Some partners are not supportive when they are seeing that Zonke has the PrEP pills or the Buckleys. It has been quite an issue also with our parents who are not clearly knowledgeable in terms of understanding what is PrEP, and with the choices or the varieties of forms of PrEP methods coming into play, this discrecy and this privacy, which has given us an opportunity to go to a clinic and only take what I feel is comfortable for me, because having to explain to other people, it has also exposed us not only to GBV, but also to stigma and discrimination amongst our peers, because when they see us trying to access these commodities through mobile clinics and our community-based centers, there has been a concern that we are already on ARVs. So we really appreciate the awareness of creation that has been going on through our social media platforms, PEPFAR social media platforms, and through us ambassadors in my community, we have been raising awareness. So I would say the variety of options that are out there are really working for us as adolescent girls and young women, and through the feedback that we've been gathering and trying to solicit and inform programming, which is the DREAMS program, has been very much helpful in terms of packaging for the PrEP pills. Some people have concerned that the pill has a burden. Some people have felt like, I would like to go for CAP-LA because I only have to go not every day to the clinic or not take the pill every day, but I have to only go once in 2 months. And also there's a concern of misconceptions and myths, which we are trying to correct. And there's also the concern of using the ring only for 30 days. But sometimes you find that my relationship is going to end before even the 30 days come into play. So now it is easy for us to say, I have a choice to use the ring because I'm in a relationship. There's also the concern of that if I start the CAP-LA, the long-term one, and then my relationship ends, what am I then going to do? Because now it means I might be at risk again of exposure. So the commodities coming into play are giving us a variety of choices as adolescent girls and young women. Thank you.
So depending on somebody's situation, or if it works for them to take a pill on a daily basis, fine. But if they prefer the discretion of an injection or not having to go to a clinic, then having those options makes
yes, that's very true.
Makes it easier.
It makes it easier because also with the ring, you can also insert it yourself, but firstly through guidance from the healthcare workers, which is uterine-friendly services that we have back in Eswatini. We have mobile clinics coming to us, and we would really like to appreciate also that approach because it is very expensive also to reach out to other community areas. There's no transportation, but at the same time, we're at the center stage of HIV and AIDS. So with the mobile clinics coming to us, it's easy to just access the commodity and receive the knowledge. So I think those options are also coming into play, and we are going to be ensuring that adolescent girls and young women critically understand the importance of adherence to these commodities. Thank you.
Okay, thank you. So I want to shift a little bit, just to kind of consider the role of civil society more broadly in raising awareness and generating demand for PrEP. Ambassador, let me start with you. I mean, certainly PEPFAR has supported a number of civil society organizations in building educational campaigns and carrying out, awareness. What, in terms of prevention, what do you see as the role of civil society as, in kind of strengthening the connection that, you talked about, that extending access to long-acting prevention tools kind of builds a bridge in some ways between prevention and the longer treatment and sustainability process. Can you say a bit about the role of civil society in that?
Absolutely. Let me say this first, that when I look at Zonke and Talon, they are examples of or people in their age groups, not them per se, but they are sitting here. Let me use them as an example. It's very possible that the close to 8 million children that, because of PEPFAR, have benefited from the interventions have been born free of HIV/AIDS 20 years ago are in front of us today. Okay, so as Gerard said, let's move away from the p-values, less than meant to real human beings. Okay, when I was working for CDC in Côte d'Ivoire, people like Talent used to be would go to PMTCT clinics and prick their toes and test the DBS, dry blood cells. So there were specimens at that time. And today, she's an ambassador, Dreams ambassador, sitting here with us. So we saved people like this at that time, 21 years ago, from HIV. Let's not lose them now to HIV, because it would be terrible, dramatic that we did all of the work and suddenly, at this point, we kind of take our eyes off the ball. So I say that because civil society has brought us a long way to where we are today, both in the treatment programs. The same partnerships that we have driven the treatment program, the scale-up, are required if we have to be successful in protecting the gains that we've had and closing the taps of new infections, especially amongst adolescent people. The civil society in the ecosystem, which I usually like to look at it as a triangle, has to be able to work with the governments of partner countries directly without us interfering in that relationship. And then we, as donors and partners, i.e. the Global Fund, the Gates Foundation, and others, PEPFAR, have to work in that triangle together. Again, it is only through that triangle of government leading and owning the response, the civil society, holding everybody accountable, including themselves. I've always said to the civil society, your role is not to hold us accountable, your role is to make sure that we're all accountable, okay? And we're all accountable, so I think that is important to the partnership and to government. I think the one thing that the HIV response has benefited a lot over the last, I say, a quarter of a century, 25 years, is the civil society. I don't know of any other disease grouping that has that kind of amount of civil society. Even infectious disease, I don't know a civil society group for malaria or tuberculosis. In non-communicables, I don't know a civil society group for cancers and for diabetes and hypertension. So I think it's a wonderful tool that I will go out of the HIV prevention realm and say that I wish that we have civil society working across other public health threats that we have, not just for HIV, but infectious diseases and non-communicable diseases. So again, I would just submit by saying that, repeating what I said, the gains we've made over the years, it's not just statistics, it's people that are sitting in front of us, the young people, that will benefit from these interventions, and the civil society must play a critical role in that equation.
Thank you. Alex and Jared, let me turn to you just to ask, in the research and development space, as you carry out clinical trials, could you just say a bit about the role of civil society and advocating and informing the work that you've undertaken? Alex, I'm looking up here, but I look over here. Let me start with you, and then I'll come to Jared.
Sure. I've been in HIV clinical research since 1996, and I've seen countless examples of the benefits of having civil society involved in all facets of essentially HIV drug development. I think you know that the phase 3 studies that we did for registration of cabotegravir were done in conjunction with the HIV Prevention Trials Network, which is an NIH-funded prevention network. Our engagement with civil society started there with the community working groups that are formed for each protocol and still continue. We continue to meet with those groups. And even beyond that process, we continue to meet with, say, AVAC, for example, and many, many other groups, civil society groups, and have had numerous discussions, especially about some of the challenges that we've had with rolling cabotegravir out. They're an incredibly important part of the conversation and all the work that goes into it. All those discussions are still ongoing. Again, even at the level that I work at, when for development of even brand new protocols, civil society is involved in the design and the review of those studies before we even enroll our very first participants. So we can't underscore enough the importance that civil society plays in all of drug development, and they're kind of a built-in piece now. It's hard to imagine them not being a part of it anymore.
Thank you. A long-term relationship, it sounds like. Jared.
Nicely said. I think I think for many of us who work on HIV, it is advocacy. Even as scientists, I think it's advocacy that drives much of what we do as well, and engagement with civil society and engagement with our own hearts and our own motivations is what gets us up every day, because I think many of us would like nothing more than to not work on HIV if we could. In our drug development process, I think the civil society, I think as the ambassador said, is part and parcel of HIV work all along the way. And that is from the products or potential products that we make to how we do the science, and then to how do we gain access. So, to Zonke's point about choice, I've been very fortunate to actually be a part of all of this, a little bit in all of the science for all the products that have been developed. And when I look across the 15 years of PrEP work that's been going on, it has been driven by community, by civil society, by individuals telling us, this is what I need.
This is what we want.
And that's what the difference in the products we have is, for being able to fit really into people's lives. And when I think about investigational lenacapavir and how we developed it, it was people saying, I would like something that could be discreet and private, that would be empowering for me, that I don't have to bring home that bottle of pills.
That's very true.
And then in the trials, for us at Gilead, engagement of advocacy in civil society is from before a word goes on paper to write a protocol. The purpose programs that are the two phase 3 studies of lenacapavir for HIV prevention, and additional studies looking at additional populations, have had standing community advisory boards before the study started, before words went onto paper, and helped us figure out how to do those studies, how to design and execute those studies better. It is because of that civil society engagement that adolescents were included in the phase 3 program, that women who became pregnant were consented to continue study drug, and to be able to gather information on safety in pregnancy and lactation, because community said to us, you cannot make a new HIV prevention medicine that might work if you cannot say whether it could be used in pregnancy and breastfeeding. And it was community that said the diversity of geography and of gender is also incredibly important from the get-go. And as much as we like p-values, once you have your p-values, when you move for access, it is civil society that helps shape all access planning, so that equity and access and partnership actually reach the impact that we all want. And in these last months, since we've had results for lenacapavir, and way back to Gilead was the first to give generic medications for HIV treatment. It is civil society who has said this is the right thing to do, and help think about the pathways that can make that successful, because it takes many, many pieces to make that all work, but it's also the engagement to make that all happen, and everyone leaning in together makes it true. So it's the entire drug development process from what you ideate to how you do it to how you really make it real.
So really starting from the absolute beginning.
Yeah.
So I want to shift gears a little bit. It's kind of an interesting period for global health right now. We see funding challenges. Donors are seized by many other issues, conflicts, climate change, lots of competing priorities. We've got the traffic jam of replenishments that's coming up. The Global Fund replenishment is certainly on the horizon. We have the looming PEPFAR reauthorization in March of next year. So pressures for many governments to kind of move on from HIV in some places. Yet, at the same time, there's also a push by the HIV Control Working Group to push for an Africa-led and financed response to HIV on the continent, and lots of other dynamism that we're seeing in terms of prioritization and really kind of shining a light and focusing on HIV. So, at this kind of critical juncture, all of these new and innovative tools and really lessons and opportunities for moving forward on prevention and really kind of thinking about the sustainability of the HIV effort. At the same time, with all these pressures on the financial side, as we kind of wrap up here, what are your top, one or two priorities or hopes, as you think about where we are at this critical inflection point? So, Alex, let me start with you, since you're here with us, coming in.
Boy, I certainly don't want to speculate on what's going to happen after January 20th. I see it as an opportunity, really. I think we're gathering enough evidence now to show the importance of HIV prevention, and so I'm hoping that we can, convince the powers that be, as it were, that about the importance of HIV prevention. That prevention is the best form of treatment. The idea is to not wait for people to acquire the infection and then treat them. That if we have the opportunity, and we do now, we're going to have these incredible tools available to us. That it's better to do it earlier than to wait for treatment. I just hope that, and we're certainly able to help out as best we can to build that quantity of evidence to make this understood as this is a normal part of wellness now. That this is so critical, and we're so close. I really do honestly believe now with the advent of the long-acting injectables that we'll be able to really bend the curve, that we'll really be able to make an impact on the epidemic, and it would be just a shame to take our foot off the gas right now.
Great, thank you. So, Jared, let me come back to you as you think about kind of the one message you might say at this critical juncture of so many new tools and innovations on the one hand, but so many pressures on the other. What's kind of your one message?
And I had a few minutes to think about it, and it's still hard. We have the tools in hand. We have the tools in hand to potentially end new infections in this country and around the world. And we've had the goals in place to end new infections, both a global goal and the epidemic initiative in the United States goal, to be able to drop new infections by 2030, which we're now 5 years and 22 days away from. And that is, we now have this short time window to really lean in, to be able to make that a reality. And I think that is really world-changing compared to all of the world-changing things that have been done for HIV treatment all over the world, to be able to turn off the tap of new infections in this country and all around the world, including in PEPFAR countries, which have such potential to implement PrEP at large scale. This is a real opportune moment.
All right, thank you. Zonke, your message.
My message to who exactly? Because I would also like to send it out to young people. Thank you. But firstly, I would like to take it to our previous conversation on civil society, that civil society has a very pivotal role to play in our lives as young people, as adolescent girls and young women, as we are disproportionately affected. We appreciate the platform that Dreams has given us as ambassadors to be at the platforms of problematic decision planning processes, where our voices are not only heard, but they're also actioned upon. And today, that is why in Eswatini we are having the different varieties of PrEP, the pill, the injection, and the ring. Civil society has a role to play in terms of lobbying. Not only the ambassador mentioned that there's an importance of collaboration. We really need to resource more funding for those commodities for us young people. We are the backbone of our own countries of the future. We are the seeds of tomorrow. And in the ambassador's word, if we were there 20 years ago seeing how HIV really was, we wouldn't be as relaxed as we are as young people, finding ourselves engaging in this risky behavior. So as young people, I would urge my peers out there, adolescent girls mostly, in Eswatini, that recent studies or data shows that approximately 4,000 adolescent girls have been infected with new HIV infections. So I believe that we're at a time where civil society needs to engage our communities, and it needs to give us ownership, because we are taking more influence from our leaders. We are taking more influence from our parents and caregivers. So it comes a point in time where PEPFAR might not be there. Not that it would not be there, but we need to be, as a country, be readily available to keep on funding these methods that are coming into play. And also, I believe that now is not the time to take our foot off the gas pedal, because we can see that as much as the ambassador has mentioned, that as much as we have achieved the 95, new infections are accumulating every year. So as young people, we need to ensure that we lead a healthy lifestyle, but also at the center stage of creating awareness advocacy, we need to be leading healthy lifestyles as well. Thank you.
Thank you. So Ambassador, turning to you for your message at this kind of critical juncture of opportunity on the one hand and challenges on the other.
Absolutely. I think there are two messages, Catherine. One is on global health as a whole. We have to look at, borrowing your words, the traffic jam that we have with all these important initiatives that are going on, the Gavi, the Global Fund, the PEPFAR reauthorization. We have to be able to remind ourselves what the fundamentals of global health is all about inequities and security. And that it is not, and I speak from the United States perspective, that it's not about others, it's about all of us. That can we afford not to do what we have been doing in terms of vaccinations, in terms of the Global Fund, and in terms of PEPFAR, that the threats that are out there, as we learned during COVID, that a threat anywhere in the world is a threat in the United States almost immediately. That HIV, if we do not continue with our efforts in HIV, as our modeling shows in 12 high-burden countries, we easily see increase in death rates over 400 percentage point, okay? And HIV, as I said earlier, let me conclude with what I said earlier, HIV is a retrovirus. It will come right back, and who knows what will happen to here, right here in the United States, and it's true for us. So I think on the global health as a whole, a question should be, can we afford not to do that? Mm-hmm. Okay, rather than can we afford to continue to do that? Mm-hmm. On HIV, we find ourselves in the response at what I call a crossroads to 2030. Come 2030, The question that we need to answer is, did we get anywhere? Did we get somewhere? And did we get nowhere in 2030? And 2030 is just 6 years from now. I think we ought to be, I hope, that when we get to 2030, we could really turn around and say, look, we got somewhere. And if you just support us a little bit, we could finish those remaining hotspots that are still there for HIV. There is 6 short years from now. So again, we have the tools in our hands. We have to make sure that the political awareness is maintained, that we are not victims of our own success, that PrEP, what PrEP Global Fund and others have done, the private sector, all these new molecules do not take the coffin market that is no longer thriving in many countries, that we do not declare premature victory, but we finish it there. We want the people that are sitting here in the next generation, HIV is generational now, the next generation should be able to sit here and say, they got it right. They control HIV. You don't want the next generation to sit here and say, they mess up, they lift the eyes off the ball. They repeated the errors of malaria. In 1955, WHO launched an aggressive malaria eradication program. Fairly successful. Many countries were about to eliminate malaria. 1969, 70, what the discussion we're having now happened. The financial constraints and whether we leave our eye off the ball, malaria came back aggressively, and the gains that were made were completely eroded. HIV, we should not fool ourselves. We may find ourselves in that, the 2030 where we said, we throw our hands up there. We didn't go anywhere with that. And the politicians will follow through and say, well, we supported it for more than 28 years. In 2030, the Global Fund would have been 28 years or 30, close to 30 years. They say we support for 30 years, and we didn't get this right. So we just sustain the HIV. Not sustain the HIV response, but sustain the HIV that is living with HIV. That's not what the people that want to sit here, the Zonke and the talents of the world that want to sit here and moderate the other session should know us, that we did.
Well, thank you. Thank you to all of our speakers for joining today. We came together to talk about HIV prevention and pre-exposure prophylaxis, and the opportunities really available with respect to existing products and many of those that are new and forthcoming, and the long-acting opportunities. But in our conversation, we've talked about partnerships and the importance of planning, and I think really we've heard a lot about the nature of persistence in research, persistence in engaging with civil society. There was even a P in terms of the scientific publications and others, but really the importance of maintaining a focus on the purpose that has driven this programmatic work and research for so many years, and really seeing the ways in which HIV prevention really does contribute to that sustainability agenda overall. So I want to thank all of you for joining us today online and here in the room, and please join me in thanking our speakers for taking time to share their expertise with us today. We're concluded.